I'm delighted to welcome you all to the second session of WReN this afternoon, and to introduce to you Rhiannon Macefield and James Glasbey. So Rhiannon is a research fellow at the University of Bristol, and James is an NIHR fellow based at Birmingham, and they're both going to talk about electronic patient-reported outcome measures and the work that they've been doing on the wound healing questionnaire, the Bluebelle wound healing questionnaire. So over to you both, Rhiannon and James.
So yeah, thanks Jane, and thanks everyone for the opportunity to present today. James and I are going to do a double act on this particular talk. We both share an interest in remote wound assessment after having surgery. So as Jane said, I'm a research fellow at the University of Bristol, and we've got some work we want to share with you, both from a UK perspective and more of a global perspective, using the wound healing questionnaire to assess surgical site infection. So a bit of background on the wound healing questionnaire. This was a new questionnaire, so an outcome measure that we developed within the Bluebelle feasibility study. It's been around for a few years now. And it's named Bluebelle after the patient, the little girl that inspired the idea for the Bluebelle study. And that was feasibility work to see whether it was possible to do a large randomized controlled trial looking at different types of dressings after surgery, with one arm of the trial being actually no wound dressing at all. And in this potential trial that we wanted to examine whether it was possible to do, we needed an outcome measure to assess the wound for SSI that could be used remotely. The patient could complete it as well as the healthcare professional, something that was feasible within a large trial with lots of patients, rather than getting everybody back into clinic to assess the wound. So the questionnaire was developed, lots of work with patients, with healthcare professionals, and the result was an 18-item questionnaire. So particularly, as I said, it could be filled out by the patient at home, or it could be used as a healthcare professional tool in hospital to assess the wound. It looks at different signs and symptoms that are indicative of SSI, and also asks about particular wound care interventions. And patients could rate whether they'd experienced that problem or that either on a scale of not at all right up to a lot, or they could answer yes, no to some of the items about the wound care interventions. And the key thing about the questionnaire was it was developed and used to date as a paper copy tool. So it was posted to people, or it was used as a kind of physical case report form in the face-to-face appointments. So whether it was suitable as an electronic tool was something that we are now looking to explore. So we thought, James and I thought, just for a bit of fun and audience engagement, we'd ask a question to you to find out how many, at a quick poll, how many of the people listening now have heard about the wound healing questionnaire to date. So if you could just give a quick poll there. Okay, and another just quick poll there. We've got a second question, just to ask if anyone has got experience of working with electronic patient-reported outcome measures. So whether it's within routine practice or as part of a research study.
You've got yes 14% and no 86%.
Great. Okay. So yeah, that's useful to know. Thanks for running that poll. So just for those of you who aren't so familiar with an ePROs, so this is an electronic patient-reported outcome measure, essentially an electronic questionnaire, if you like, or tool. And there's many advantages to using an electronic tool over the paper copy traditional version. It can be an automated process, so can be sent electronically either by email or by a text message that takes people to a link to the questionnaire, for example, and this can be set so that you don't have to physically keep an eye on dates of surgery and send those things out in the post. And obviously reminders can also be automatically sent in the same fashion. Because people are filling it out online, it reduces all that need for somebody sitting back in an office receiving all of those paper copy things and entering them into a database. So of course saving a lot of time, a lot of money, and avoiding potential errors of mistyping when that's being transcribed. And of course these kind of electronic tools now have really fancy ways of making sure that people don't make mistakes when they're completing it themselves. So you can have filter questions that hide some things that might not be relevant if they answer in a particular way to a previous question, and all of those things that you can't actually do with a physical piece of paper. So loads of advantages. Of course, there's no printing or postage costs involved, and arguably it can be much more convenient for people because you can essentially respond to the questionnaire wherever you are on your smartphone or through an email link or something like that. And of course, from a researcher side or a clinical team point of view, you get that data instantly. So a much quicker process in terms of data capture there. But of course, there's things to consider that are potentially disadvantages, or certainly things that need to be thought about in advance. And obviously that the major one is the access issue. So in order for this ePROM idea to be effective, it has to you have to have access to a smartphone or access to a tablet or computer to be able to take part. It requires a level of ability, so technical ability to actually to use those sorts of systems. And of course, you need to have an email address or a text message that's recorded accurately to make sure that your participants receive the link when you want them to. Again, the flip side is that there are costs to designing these things, having the software to create the survey, to send out the messages, and there are costs to that, of course. And the other issue is to consider about data protection and security. So we wanted to explore some of these things using the Bluebelle wound healing questionnaire, and we've got an opportunity in Bristol to see what the feasibility of collecting automated data, patient-reported SSI information using an electronic PROM. And this is part of a wider piece of work, a quality improvement programme, but we are sending out a wide, from a wide number of specialties. We are automatically sending out the wound healing questionnaire at 30 days after patients have had surgery for those patients who have a skin wound. And we're asking them to complete and return the questionnaire to us. So it's giving us a real insight really into whether people are able to engage with this kind of reporting, what the feasibility might be like for us to want to look at automated remote wound assessment in this way. We've got very fresh data. We only started this work at the beginning of August, so the initial month has shown us the following results. So about 40% of people are actually opening and engaging with this kind of survey and returning the data to us. So looking at this, now's the juicy bit, we're able to explore who's responding, who's engaging with this type of electronic reporting, and importantly, who isn't, so that we can try to potentially think of ways to target those people who we're not getting a response from, and think about how we might be able to maximise this kind of data collection going forward. So we've seen that so far in our initial month, that actually patients between the age of 60 and 69 are more likely to respond. We're not seeing any difference between the surgical specialty or the types of surgery that patients are undergoing in terms of response rates. We're seeing a slightly better response rate to those people responding by text rather than email. So this is very initial early data that we are going to use going forward, which is really, really useful. We're starting to think now about how we might target those people that aren't responding, and how we might implement certain interventions to maximise those response rates. So things like different languages, translating the questionnaire into anything but other than English, and also to produce some kind of flyer that could go in with patients' pre-surgical information to let them know to expect this questionnaire, to see if that will increase response rates. We're going to trial that in one surgical specialty going forward. So I'll stop there and just hand over to James, who's going to give more of a global perspective on using the wound healing questionnaire. Thank you, James.
Thanks, Rhiannon. Really interesting to hear about your experience, and I'll just transfer to my presentation so I can talk to you a little bit about my my experience too. So we absolutely love the wound healing questionnaire, and it's lovely to be able to share it with you all as the audience today. My caveat is that I actually haven't been using this as an electronic patient reported outcome itself, but have been working with colleagues in 7 different countries around the world to deliver this over the telephone. So it's a clinician administered questionnaire that is then started back by the patient. However, the fact that we've been contacting people by telephone and collecting really detailed information on the pathway of contact, from everything from how many times we tried to call people to the type of phone that was used and who owned it, we can hopefully make some inferences about how feasible it might be to collect electronic PRO data across different settings. So another piece to add to the puzzle that Rhiannon's proposed to you, but perhaps not the full picture yet. Maybe in 2 or 3 years' time, we'll be able to provide something a bit more comprehensive on this topic. Lots of exciting work. So we've spoken a little bit about the priority of SSI on the global agenda earlier. And what people have typically thought of as being the gold standard for wound for diagnosis of surgical site infection has been bringing people back to hospital at 30 days after surgery in order to review what happened to them after they were discharged with a trained surgeon, a trained clinician. So as we can see, that's probably quite an ineffective and efficient, and particularly during the COVID pandemic, that's obviously not been possible. However, for many colleagues in low middle income countries, this has always been really challenging, with patients sometimes living very remote to the hospital, traveling for 12, 14 hours to come to a central tertiary hospital for operation and then returning home again after their discharge. And the idea of kind of coming back to hospital and taking more time out of work and time, often if these people are young and providers for family, it's always been challenging. So it's an important issue from a global perspective, and not one that's just been resigned to COVID-19. But hopefully this allowed us all to unify around the idea of this being an important research topic. So what we've been doing with the wound healing questionnaire is firstly to adapt and validate it for use across different settings and in different languages. So working with colleagues in the 7 different low middle income countries spanning 3 continents, so Mexico in Central North America, 5 countries in Africa, and then in India. We've been doing cognitive debriefing interviews with patients and doing clinician interviews and focus groups in order to adapt this questionnaire. And we've now got it optimized for use with patients of different health literacy and across different languages and constructs in 10 different languages. So lots of hard work done there, but hopefully now we've got this optimized questionnaire that we can use across different contexts. So that's number 2. And then what we did to kind of test the questionnaire on a global scale was to use something called a study within a trial methodology. And this has been largely reserved to the UK so far, but the idea is that you can leverage the platform of a randomized trial where there's a huge amount of funding that's been used to develop an infrastructure and database and quality assurance procedures. And you can add a key methodological question, 1 or 2 methodological questions, and answer that to both run that trial specifically more effectively, but also to learn how to run research better in the future. So if you forgive me for the analogy, then it's kind of this sort of F1 type recommendation where you can make small tweaks to your procedures, which make big differences at a large scale. So specifically within Falcon, which you've heard about already, what we did is in a subset of patients, about a sixth of the patients that were recruited to the trial, so about 1,200 patients in total, we did a telephone call and administered the wound healing questionnaire about 3 days, well, 2 or 3 days before the patient was due to come back for their in-person follow-up. And what allowed us that allowed us to do is to make a direct comparison of what the results of the wound healing questionnaire were with what was detected by the clinician at 30 days. Now, I guess you could say what happened in that 28 to 30 days, but we know that it's very unlikely that people will have the first manifestation of a wound infection at like 30 days after surgery. They may have a continuing wound infection, which would be detected by both methods, but probably just a very small risk of theoretical bias there. And so we had this information by telephone using the wound healing questionnaire and the kind of gold standard treatment. We also used some video follow-up. Stay with us and we'll talk to you about that in a little while. So as I said, so this doesn't count as a ePRO in the same way that Rhiannon was describing, in that it wasn't truly patient completed using text messaging or an app or entirely patient delivered. But what I hope it does give us is some deeper understanding of the pathway and potential accessibility of ePRO usage across different contexts. So in Falcon, we had, as I said, about 5,500 patients. In Talon, the data I've presented here, about 1,050. And this is what we found. So the questionnaire was translated into 10 languages, but actually there was about 5% of the questionnaires were done in other languages and translated by the questionnaire administrator. And that includes several dialects in northern Ghana, for example, where there isn't actually a written version of the language. So that was the only way that it was able to be delivered. So very kind of pragmatic data. Interestingly, 2/3 of the time, the patient used their own phone, but 1/3 of the time they required use of another patient's, a friend or a relative or a healthcare worker's telephone. However, you can see that the overall feasibility of contacting people by telephone was really high, 90%, which is a bit higher than we would expect in our general loss to follow-up calculations for a trial like this. So I think what this shows is that there was resilience within the system for patients to adapt and find new ways to make sure that they were able to pick up the telephone call. And that included everything from patients actually setting a time themselves with the clinical team and traveling outside a village to make a telephone call, or perhaps contacting a family member to use their telephone instead. So 90% overall feasibility, people were able to reach by telephone. So that, I think, to me, says that ePROs would probably be feasible to deliver in a similar way as we've seen in the UK. Interestingly, we had a really high patient acceptability satisfaction with use of telephone for follow-up. Patients reported strongly in both interviews and the sort of semi-qualitative data on a survey that they were very satisfied with having a telephone call, and it made them feel more engaged with their clinical care, and they like receiving more follow-up. So I think that was really positive too. In terms of the telephones that people used, actually, again, 2/3 of the time, there was some kind of smart capacity or video capacity to the phone of the people that were able to be called. So again, this wasn't a use of an ePRO, but it does suggest to me that some kind of app-based system may be feasible for some patients, but with a whole third of patients not having access to a smart telephone, perhaps a system with text messaging or something similar to that might be a stronger, more feasible way of delivering this across different environments. One important thing with the trial kind of crossing into COVID, and you might have seen in the recruitment graph, there was a slight, despite its really impressive recruitment, there was a little deflection when COVID started, and trial recruitment has suffered around the world during COVID. We were able to reach a huge amount more patients by telephone when travel was restricted. So I think this kind of move towards telemedicine methods of remote follow-up is really timely and important. So just a quick snapshot of the data there today, and I would love in a future meeting to present some more detailed information about the validity and reliability of that method. But what I think we can take away from this is that the use of remote follow-up methods It's really important now because of COVID, but it's always been important in a global setting. And it does appear to be feasible to use a mobile phone for follow-up across all different contexts. And I think that's promising for the use of ePROs in future research. And we think it might be more efficient, and it did retain more patients than in-person follow-up alone. And patients seem to really like being contacted by telephone. So I would leave with you this key methodology question is, can truly kind of patient-reported electronic PROs be used across lower resource settings? And that's something that we perhaps would hope to answer within the next few years. But a really exciting area, and I'm delighted to share the stage with Rhiannon to talk about this today.
Thank you both very much indeed. And we have got a question already in the Q&A, so we'll come back to you at the end. We are running over, so James and Tom, you've got the challenge of bringing up the rear in the last of the 4 sessions and making sure we come back into time. So now I'm delighted to introduce Amber Young. Amber is a consultant in paediatric anaesthesia at Bristol, and is also an NIHR advanced research fellow. She's been involved with WReN since the beginning, representing the burns field, and we're delighted to have her today talking about outcomes research.
Thank you very much, Jane. Thank you very much indeed. I'm a paediatric anaesthetist, but I'm involved in the care of patients with burns. And over the last 4 years, I've worked with the NIHR to achieve a core outcome set, which I'll describe shortly, for burn care, wound management, research. I've got no conflicts of interest, and all photos are reproduced with permission. So, as everyone knows, burns are common. They may produce prolonged hospitalisation and long-term disability. They're also, as you can see here, expensive. Clinical decision-making is difficult due to a lack of evidence. Producing the evidence base that's required for burn wound management is hampered by many different outcomes reported across trials, making evidence difficult to synthesize and put together into stronger evidence for clinician use. So these papers produced by our team demonstrate the problem with a lack of evidence. It results in a variation in care and an impact on patient outcomes across health services because of that differing in care. In terms of, for example, here, amount of fluid to give, use of antibiotics in treating infection, and treatment of small area burns. So we've shown that lack of evidence affects practice, but more importantly, affects outcome. And if there's a variation in outcome, it means per se that some patients will experience poorer outcomes. So this is the Cochrane collaboration and shows why one reason why there's a lack of evidence in burn care. The Cochrane collaboration compare and contrast research studies to get strong evidence for clinical decision making. Between these dates, 2012 and 2016, there were 9 Cochrane reviews specifically on burn care. None could draw firm conclusions due to poor outcome reporting as one reason. They couldn't compare like with like, as different outcomes were reported from different studies. This is a waste of public research monies and of patient input. So is this really true? Is there a problem with multiple outcomes reported across burn trials? Is this a big problem? In order to answer this question, we took a systematic review of all randomized controlled trials in burn care over a 5-year period. We extracted all the outcomes reported in all the 147 trials that fulfilled our criteria. As you can see, we found 955 unique, that is, different outcomes reported across the 147 trials. Not only that, there wasn't one single outcome reported in all the trials. So yes, this problem exists and is likely to be a key reason for not being able to synthesize evidence. So as we can see from that systematic review, studies looking at burns assess the impact of care on multiple different outcomes. For example, healing time, length of stay, incidence of infection, scarring. So we cannot compare studies as we are comparing different outcomes for evidence of intervention effectiveness, i.e. we're comparing apples and pears. What's the solution then? Reporting an agreed minimum set of the most important outcomes, a core outcomes set, while still allowing researchers to report other outcomes, will solve this problem and allow effective evidence synthesis and achievement of an evidence base for burn wound management. So a core outcome set is a minimum set of outcomes to be reported across all trials for one condition identified through stakeholder consensus. And over the last 4 years, I've worked with burn patients, parents and professionals to agree an international core outcome set for burn care wound management research to allow consistently reported outcomes, evidence synthesis, and thereby an evidence base on which to allow and support clinical decision making. And this is what we did. We used approved and well-tested methodology to develop the core outcome set in 3 stages. Firstly, development of a comprehensive long list of candidate outcomes through the systematic review I've described, interviews with patients and healthcare professionals, and a previously reported, patient-reported outcome measure review. Secondly, a 2-round online international Delphi survey prioritised the outcomes in the long list. Finally, a face-to-face consensus meeting with 2 rounds of voting was held with stakeholders, including patients, to agree a final core outcome set. Working with patients to achieve a core outcome set is vital. Patients often think different outcomes are important compared to clinicians, quite commonly, and often favour longer term outcomes as more important. How they feel, how they move, they function, or how they survive after injury. We undertook 25 interviews with patients and parents of patients to understand what they consider important outcomes after a burn injury. These were fed into our outcome long list with outcomes from the systematic review. And then we used this combined long list to develop our survey questionnaire. And this is an example of the questionnaire. So the long list of outcomes were grouped into those that are similar, and we ended up with a questionnaire of 88 outcomes for the first round. In the first round, patients and clinicians were asked to rank the outcomes, as you can see there, from 1 to 9, not at all important to very important to be included in a core outcome set. Preset rules were adhered to about thresholds for when outcomes were allowed to move to the second round of the survey, and participants were allowed to add additional outcomes. In the second round, as you can see on the right of the second round of the survey, participants were given their previous score. So you can see on the right, it says you rated this outcome 4, and they were also given the median of the group for that outcome, and you can see that was 8. Participants were then allowed to rescore each outcome based on this information to achieve consensus. And this is a fairly common way to achieve consensus. Through social media, professional organisations, and a lot of personal emails from me, we finally got 126 UK patients and parents and 668 international professions from 77 countries, from every continent except for Antarctica, and from 4 World Bank income groups, as you can see from the map on the right. So we started off with more than 1,000 candidate outcomes grouped into 88 questionnaire outcomes. In round 1, 87, so pretty much all the outcomes were rated important by more than 50% of the participants, and 14 additional outcomes were suggested. 1 outcome only was dropped. In round 2, 20 outcomes were rated important. We asked the participants to be stronger in their views about whether an outcome was important or not. 11 outcomes in round 2 were rated as important by either professionals or patients. All of those were taken through. And at our consensus meeting, we ended up with 31 outcomes which were discussed. Some of those were merged because they were very similar, and 17 outcomes were voted on to produce a final core outcome set. So the final core outcome set, and this is the group that we would like reported in every trial on burn care wound management: death from any cause, serious complications with pre-agreed complications, including wound infections, sepsis, thromboses, ability to do daily tasks, time to heal, neuropathic, that is longer term pain and itch, patient psychology, and time to return to work or school or previous occupation. Our aim is that researchers in the future will be required to report these core outcomes so that evidence can be compared and contrasted, comparing like with like, to provide high quality evidence to underpin medical decisions. This will end up reducing variation in care, allow national policies, and improved care. This is Kieran. Kieran was scalded to almost 75% of his body from bath water. Kieran was burned about 22 years ago, and one of the first children with burns I looked after. He spent months in hospital in intensive care in the operating theatre. He survived, as you can see, and now has bad scars, some trouble with joints, hair loss, confidence issues, but is reasonably happy and has an apprenticeship. And I think he recently got engaged. We need to undertake research wisely so that patients get the same standard of care, the same care wherever they are. We cannot do this without evidence to support clinical decision-making. If we report different outcomes across every trial, we cannot synthesize evidence. So we need to use core outcome sets that have benefited other healthcare areas to allow us to understand what is important to patients and to provide evidence to underpin medical decision-making to provide the best outcomes for patients with burns. Thank you very much.
Thank you, Amber. That was really interesting, and you rattled through it in record time. And I think we had an earlier presentation of your work 3 or 4 years ago, actually. So it's great to see that it's now completed. So and I've certainly got a couple of questions for you in the Q&A slot. So thank you. I'm now delighted to introduce to you Catherine Arundel, who is a research fellow and trial manager at the York Clinical Trials Unit. And she's going to talk about assessment of healing in open surgical wounds. So welcome, Catherine. I think this is your first presentation at a WReN meeting, so welcome.
Yes, I'm going to talk this afternoon about assessment of healing in open surgical wounds. So as I'm sure we all know, assessment of healing, the gold standard is direct visualization, and that allows us to have an objective assessment and an accurate assessment, particularly of the specific nuances of a wound site. So things like the exudate level, the tissue type, colour and condition, how the wound edges are perhaps looking and coming together. And that accurate assessment is really crucial for ongoing care, particularly if that's still required. Direct visualization, though, can be problematic to achieve, and there are a range of different reasons for that. So there can be just quite simply the challenge of arranging those assessments or appointments, so patient availability, clinician availability, willingness perhaps to attend an appointment if the patient deems that wound to be healed, and perhaps scheduling if the patient has returned, say, to work. Equally, things like patient location, so perhaps where clinically we're covering a remote or large geographical area, or using perhaps a hub or spoke type of arrangement for that particular clinical specialty. There are also practical considerations to think about, which may be difficult to facilitate. So things like the patient needing mobility aids, hospital transport, friends or family support, perhaps to attend that appointment. There's also a burden both for patients and healthcare professionals in undertaking direct visualization. So this can be expensive to achieve. So from an NHS perspective, travel time and costs, perhaps further treatment costs can be an impact there. And for the patient, the opportunity costs, so taking time off work, or even the financial costs too, so the cost of the travel, the cost of parking at the hospital, and so on and so forth. The time-consuming nature, particularly as I've mentioned, if we're covering large geographical area, means that potentially we're diverting healthcare resource away from other important things. So recruitment of patients to ongoing trials, or just quite simply from a clinical care perspective, the time needed to care for those with more complex or problematic wounds. There's also the impact, of course, on study data collection, and it's particularly pertinent here today talking about wounds research. Missed appointments and limited data can be a real problem, and of course that's particularly critical if healing is the outcome of interest in the particular study. The recent COVID-19 pandemic, of course, made direct assessment more difficult to undertake. Clinician and patient safety was, of course, a key concern. Patients or clinicians needing to isolate, patients' unwillingness to perhaps attend healthcare settings, clinician exposure to patients and the risks that carries, and also redeployment have all made this more complicated through the pandemic. As a result, we can start to then perhaps think about alternative healing assessment methods, and there are a couple of options there, which will allow us to visualise and get some level of objective healing review. Both options are increasingly common, particularly as a result of COVID-19, and there's a real potential with both of the options here, telemedicine and photography assessments, to reduce the patient and clinical burden. There's obviously, of course, a potential cost saving. And we've seen the increasing rise of use of mobile phones, video communication, and other such devices as a result of COVID, which might make this more feasible than it perhaps was thought before. Both the idea of using telemedicine and photography assessment allow a range of different options in terms of collecting that information. So perhaps store and forward, so to collect it at the time point that you're reviewing that patient and then provide onwards for review. Local infrastructure, training and clinical need. And of course, before we use any of these types of alternative methods in a research study and clinically, we need to be sure that we've mitigated all of the potential obstacles and that this is a reliable route to a healing assessment before we implement more broadly. The rest of the presentation here today will focus primarily on photograph assessment, but there are, of course, elements that will be transferable across into things like use of apps and video conferencing, and there's certainly more to explore there at another time. So in terms of thinking about photography assessment, and this is an alternative healing assessment. So there's a lot of existing literature around using photographs for infection assessments, and also with a particular focus on patient-taken photographs and in primary closed wounds. Existing literature suggests that using photographs is a promising initiative and that there is some acceptability to patients. So in terms of it being a promising initiative, in the work by Totti and colleagues, there was around an 85% agreement in photography assessment versus face-to-face in terms of assessing surgical site infection. And in the work done by Reeves and colleagues, there was a reasonable uptake of patients returning photographs at 35%, although this did highlight some elements that should need to be considered around confidential submission, linkage with data sets, etc. There is, however, limited evidence on the assessment of photography for wound healing. We began to explore this in some earlier work that myself and colleagues did as a programme grant for applied research, looking at patients with surgical wounds healing by secondary intention. From our pilot with 40 participants, we had 10 wounds that were healed in total according to clinical review, and blinded assessment of photographs taken for that confirmed 8 as being healed. That corresponded to face-to-face confirmation of 7, so there was reasonable agreement there. As a result of that work and other studies that are now ongoing, we've been able to identify some of the challenges and potential solutions to thinking about using patients taken photography as an option to assess wound healing. So in terms of the challenges, technological availability and competency is a key one here. Do patients have access to a camera device? Do they have access to an email to return the image? If we're thinking about using photography within the NHS, is that an available option? And thinking about video technology as well, is that there as a routine use? Are patients able and willing to engage with this? We think perhaps this might have improved due to the COVID-19 pandemic. And so this might make this more normalised. How do we transfer the images from the patient to ourselves as the research team or clinically in order to review these? So we know from the literature that I presented just previously that Reeves et al. Were thinking about using a confidential web link sent by email for the patient to return the image. Is that necessary if patients accept the risks to sending an image themselves? Are patients more likely to provide their image if they're assured of the security of that image transfer? How do we then link up those images to other data sets? We need to think about how we prevent the inclusion of identifiers in the image. So if the patient takes the photograph with a clinical letter in shot, how do we try to ensure as much confidentiality as possible? What about if they include their name or date of birth in the email? How do we make sure that patients are providing the image as securely as possible and maintaining their confidentiality where we can? And things like secure web links, image portals, and guidance documents might be an option there. To ensure image quality, guidance documents, both for clinicians and patients, particularly with taking both options of photography there, are really important. And there's a real importance there to testing of that with patients and public before we implement that. Accurate assessment, particularly with wound photography, can also be difficult. And so it's important to have dedicated and experienced reviewers who can help with doing that. We've found in review of photographs and thus far in previous research and ongoing research that the presence of dead skin across the wound can make assessments of healing quite difficult. And it can also be difficult to view the wound, particularly if that wound is located in a crease on the body. We therefore need to think carefully about how we ensure accurate assessment. Yes, we can say clinically to make sure that that dead skin is removed, but can we do that with patients? Do we run the risk of the patient being too hard on that nice new healed skin and perhaps then running the risk of that wound reopening again? Equally, we've got to pick those reviewers correctly, and we need to consider the burden of that on the patients, and perhaps also consider payment or publication in reward for that activity. So as a case study, we'll use the Swishy 2 study here, which is an ongoing study, and we'll talk some more about that tomorrow. But this is a pragmatic multi-centre study looking at patients with open surgical wounds and assessing negative pressure or usual care in terms of wound healing. So within this study, patients are followed up by telephone on a weekly basis until the wound heals. And at that stage, when the wound has healed, traditionally we would do a face-to-face visit to confirm that wound healing and take photographs for blinded outcome assessment. The primary outcome for the study is time to healing, which we define as complete epithelial cover in absence of a scab. So prior to COVID, this was how our wound healing pathway looked. The patient confirmed with the treating healthcare professional that that had healed. We then undertook a face-to-face assessment and took photographs by the research team to allow us to do blinded outcome assessment. We also asked the patients if they would take a photograph themselves, if agreeable, particularly if the patient had moved location, as we might not be able to do that face-to-face assessment. And this was just a fallback option if that really wasn't going to be possible. We also reduced the number of post-healing face-to-face assessments down from 3 to 1 due to capacity and scheduling difficulties. During COVID, of course, we would have loved to have kept that same pathway, but things were clearly, as we all know, very difficult, particularly during the early part of 2020. So we accepted patient-reported healing, particularly if patients were self-caring, and we found at a number of patients that they would be providing their own dressing changes. We aimed to undertake face-to-face assessments if at all possible, but otherwise did that remotely. So that might be a photograph taken by a patient if agreeable, or also using video communications in order to assess the wound in a live setting. Following on from COVID-19, we've tried to merge the pre and post-COVID together to allow us to assess patients taking photographs. So we have a 3-stage model now that incorporates the key principles of the original assessment pathway, but with the flexibility to accommodate changes that may or may not happen as we move forward through this pandemic, but also, as I say, to allow us to begin to assess the comparability of clinical and face-to-face versus patient-taken photograph assessment. Face-to-face will always be our preferred option, with video call technology and taking of a screenshot of the wound as a compromise. Assessment by telephone is a third-line option if required. We're now asking all patients to take an image of their wound to allow us to assess the validity of those in-COVID images versus pre-COVID clinical images. This has also afforded us the luxury to explore the feasibility and acceptability of patients. And as we've noted before, the literature is currently lacking there. So as I've mentioned, we do blinded clinical review of photographs within the study, operating a consensus definition. So at initial review, all review independently of each other, our 3 reviewers. If all 3 agree, then that's the consensus. If not, then we revert to a second review. And if there's still no consensus, then on healing, we accept the majority verdict. We've reviewed 72 images to date, of which 16 have required a second review, and 2 of those were patients taken. As I mentioned before, there have been difficulties with image review, particularly with that dry skin sitting on top of the wound. And as I mentioned there, there's a risk if that particularly pertains to those images that are patient taken. How do we ask patients to ensure that the wound is clear of dead skin without running the risk of that skin breakage? And that's something we need to consider going forward. In terms of acceptability, so since March 2020, we've undertaken a number of post-healing assessments at York Trials units on behalf of our research sites due to the impacts of COVID-19 across the NHS. We've undertaken 25 of these and requested of those 25, 16 patients to return their images. We've received 10 of those, and in the main, the reason for non-response was due to technological issues, so having no camera or no email. The clinical reasons, we had a bandage covering the wound and the patient was bedbound, and a second patient was bedbound, which limited the ability to take those. Of the images that have been returned, we're not aware that any other patients have returned images, but it may be that we have also got additional patient images in our set, but we've just not been able to denote those differently to the clinical images so far. In terms of the acceptability here, it's really important just to reflect back on the literature. So generally speaking, the acceptability has seemed to be reasonable thus far, with some scope for improvement. The limited response here and the technological difficulties perhaps point towards the differences in the patient population. Patients with open surgical wounds tend to often be older. Our pilot study found a mean average age of 57.8 years. Patients are often living alone, so may have limited support, may have ongoing comorbidities. There's potential lower socioeconomic status and frailty at play as well, which may limit abilities to take photographs and to return those. In terms of future research areas then, so that we have begun to lay the groundwork, perhaps for thinking about patient-taken photographs in open surgical wounds patients. Currently, we're also undertaking some acceptability work to look at this further through a Yorkshire and Humber Research Design Service public involvement grant funding. This will use focus groups to allow us to identify the acceptability, barriers and facilitators to undertaking this, and to identify potentially how we could remove some of those barriers going forward. Provided there are appropriate methods to improve the acceptability and uptake can be identified, then we will need further well thought out and innovative designs to assess the effectiveness of strategies, both for patient-taken photographs and also video calls for assessing healing assessment and or potentially surgical site infection assessment in open wounds too. We've of course focused on open wounds here, but there is also scope for this to move and transfer to other groups as well. And we feel that potentially something like a research for patient benefit or another funding stream may be appropriate as an initial step here. So just to pull this all together, we know that direct visualization of wounds is the gold standard method. Remote assessment offers a potential alternative here. It sounds like it should be simple, but perhaps it's far from it. And so we must really consider how to facilitate this before we further assess the appropriateness and implement this going forward. We need to consider the challenges given the patient demographic. And so hopefully the ongoing work currently will help with that, with scope to build on this further. Thank you.
Thank you, Catherine. That was really detailed and really outlines some of the challenges that we have in making decisions about moving away from face-to-face, both in clinical practice and in research. Obviously it dovetails very nicely into the last presentation of this session, which is about video assessment in acute surgical wounds.
Thanks, Jane. We'll do our best to keep it snappy because it's nice to have a bit of discussion and question and answer. So we're going to talk about our experience internationally and in the UK with video assessment of the surgical wound, and Professor Tom Pinkney's here as well, and we're presenting together. So what we're hoping to get across is the need for kind of rapid evidence to evolve, as we've just been hearing from Catherine, to support video follow-up, and now it's kind of being broadly adapted into practice. Some of the challenges with it perhaps, and what our current experience has been within a global randomized trial, and then what we're thinking of doing in a massive UK trial and that Tom's leading, and we'd love to get your feedback during the Q&A session. We'll ditch the questions, but we're going to ask you whether you've used video follow-up and whether this was before or during COVID-19. I suspect that more people are using it during COVID-19 in our experience, but we'll probably skip that for time. So as we said, SSI is very common. It has this gold standard assessment of bringing people back to hospital. That's been really troublesome during COVID-19 because of risk of nosocomial infection in the outpatient setting. So what we've seen is this rapid resurgence of video wound assessment where people have just been using it because it's available and it's possible and it allows you to get a face-to-face interaction. But actually there is no evidence to support its reliability or validity, despite being a very attractive way of being able to see patients face-to-face. However, this kind of adoption does have implications for clinical safety and for research, and this kind of urgent focus of evaluation we think is really important. It may be that we overcall wound infections and give people problems with antimicrobial resistance. It might be that we're missing wound infections and patients progress and get worse wound infections before they present, etc., etc. So really there's a need to examine this. And why do we think this is a problem? Well, we've looked at our global Surge 2 data, which was a prospective study of about 15,000 patients published in Lancet Infectious Disease. And this didn't include videos, but when we telephoned patients with we didn't use the wound healing questionnaire or any kind of schedule, it was just whatever had happened locally. We think that the number of SSIs detected was decreased by about a third. And we know from other research that effectively with wound infection, the more you look, the more you see, and the more methodological rigor you put behind your SSI assessment, the more likely you are to detect a high wound infection rate. So in a well-conducted randomized trial in abdominal surgery, we expect to see about a 20% wound infection rate or higher. But in registries of abdominal surgery, where people are just inputting them kind of willy-nilly according to no definition, you see a kind of 1 or 2% rate detected. So this kind of need for rigor around video follow-up is really important. The wound healing questionnaire is a great first step in that direction. And our question really is: does video enhance? Does it add anything else beyond the questions that can be answered on that questionnaire? So what exists in the literature? We heard a little bit about that from Catherine already, but we've done a systematic review as well and combined some of the data with our cohort studies data. We only managed to find one study regarding video wound assessments, and it kind of talked about whether you could see redness or pus over video. There certainly wasn't a robust validation or reliability analysis. So what are the big problems with wound healing? Brittany's made the press again recently, and has always been had problems with cameras being put in her face. But actually, there is lots of data governance problems with transferring videos and images for use in this setting. So one of them is that once you take a video of a patient and you store it, technically it's part of their source data, it's part of their clinical records in many countries. So that has to then be linked to their original data. There's all sorts of problems with the security and patients feeling confident that things will be kept anonymized. So actually what we would propose is something a little different. Oh, sorry, I think I missed a slide there. So what we would propose actually is the idea of a live video, where in fact there is somebody on the other end of the video call, and they are able to interact with the patient as they would in a clinical setting, to examine the wound and to ask them to manipulate the wound perhaps and make sure it's fully uncovered. And we think that might be a nice way around the data governance issues that we've seen with video follow-up, in that there's no storage of data, no transfer of data. The only thing that's recorded is the kind of live wound assessment information. So that's what we've been doing in another study within the global surgery portfolio called Cheetah, which is about halfway through recruitment. It's the 13,000 patient cluster randomized trial looking at the practice of changing your gloves and instruments at the end of an operation to reduce surgical wound infection. Perfect. So Talon Plus, we called it, for lack of a better word. I'm sorry, cheetahs don't have talents, but we thought it would be good to keep the same name. And this study is looking at the use of live video within the follow-up pathway. Again, I've just got the feasibility data for you today, rather than anything to do with validity or reliability, but I'd love to present that to you in the future. So what have we designed our schedule within Talon Plus to look at? Well, effectively, it's designed to emulate as much as possible a clinical encounter if you had a patient in front of you in clinic or on the ward. So it starts with confirmation of consent, making sure that the wound is fully exposed. If they have a dressing available, we want to make sure it's nice and safe for patients. And then we do a live video examination, which exposes and looks at all aspects of the wound to start off with, and then in particular at any areas of concern if needed. And one of the aspects of live wound assessment, which is quite attractive, is if there was, for instance, some sign of swelling or pus being discharged, we could ask patients to gently manipulate or push on that area to see if anything that could be expressed, for example, as we would do in our own practice if we were examining patients in person. We would then use the same CDC, Centre for Disease Control criteria that we would use if a patient was in front of us in clinic, but over video, and we wouldn't record or store any data as part of this assessment, other than in some cases for processes of quality assurance, but that's a sort of methodological point only. So really mimicking a clinical interaction, but over an online sort of WhatsApp call or whatever platform is available locally. So Talon Plus so far, we've recruited 600 patients too, and we just focused on Nigeria and India, where the teams felt that their patient groups would be most likely to have access to video calls. And what we've seen so far is, again, almost a 90% rate of a successful video call being conducted. And again, not all of those patients actually had a video phone, but found some other method of getting that video call done. So borrowing a phone from their local community healthcare worker or family member or friend, for example. We saw 80% of patients just having less than 2 attempts to contact them. Interestingly, there didn't seem to be a huge difference. I was expecting patients in urban areas to be much more likely to have a successful video call, but actually there doesn't seem to be a difference between urban and rural settings. But there is this quite stark difference across different centres and areas. So Manali, which is at the foothill of the Himalayas in India, they had a 2/3 of patients they were able to reach by video, and a third that they weren't able to. Is much higher in Ile-Ife, which is a bustling city in Nigeria, for example. The patients who were unable to contact, commonly it was to do with image quality or data being unavailable, or sometimes patients being unable to use the camera. So there's a sense, I think, from this data that video calls do seem to be possible in lots of different environments. They might be variable based on the kind of connectivity and data quality that's available, but I think really promising for the future. So I'll hand over to Tom to talk about our emerging experience in high-income countries, including a snazzy video talking about the problems that we've been facing in the Rossini 2 trial. So I'll hand over to Tom Pinkney now.
Great, thanks, James. I can't turn my video on, but you know what I look like. So we encountered, we were thinking about this from a global centre view because of some of the geographical issues, and then COVID made us think about it much quicker in Rossini 2, which is on the next slide, which I've mentioned earlier this afternoon. I'm contractually obliged to talk about this in every talk I give. A multi-arm, multi-stage study of abdominal surgery in 3 interventions. Just on the next one, James, if you would. And in this trial, we've got the interventions we mentioned earlier, but that's not so important, and neither is the design. The key point is that we mandate, because we thought it was the best way of doing it, a face-to-face review of the wound before the patient goes home at about day 5 to day 7, and then again at day 30. So the patient comes back to hospital to a research clinic or to a routine clinical appointment where we do both surgical follow-up, histology stuff, and also a wound assessment by a blinded wound reviewer who was not in theatre, therefore didn't know what happened in theatre. And then COVID came, and we've got this video which we want to show because it shows James's 6-pack and my daughter and cat very briefly. If you can try and show it, James, if you can. It's only 2 minutes long. And this we created the kind of post-COVID.
Hello and welcome to this June 2020 Rossini 2 trial update. I hope you'll all remember Rossini 2 is our large multi-centre RCT looking at 3 in-theatre interventions to reduce wound infections after all abdominal surgery. And it was all going really well. We've been open about a year, plenty of sites open, 150 patients a month or more. We'd actually got just under 1,000 patients, 993 patients by mid-March, and we were ahead of our recruitment curves, and then you know what happened. So, of course, like everything else in the world, it's all on hold at the moment, but we've been making the best of it. The team have been catching up on a load of data entry, data cleaning. We've been getting some protocol amendments through and some little tweaks to the study to make it even better. And most importantly, been working out how to successfully reopen the study in the post-COVID NHS. There are 2 changes to mention now. We're collecting COVID status, so that's COVID swab results and antibody results when patients go into the trial, so we can control for this in our analyses at the end. And we're changing how we're going to follow up patients. You remember patients used to have to come back for an in-person wound review at 30 days, and that's just not going to be happening for the foreseeable future. So we've changed the follow-up structures to actually allow telemedicine and particularly video consultations, so video wound assessments after discharge.
Tom, you're on mute! Unmute your mic, Tom!
We do need to get loads more sites still open and involved in the study. There are still, after all, 5,600 patients still to recruit.
What? 5,600?
That's right, 5,600 patients. So we do hope we'll be able to get cracking pretty soon, and from all of us at the Rossini team, thanks again for your support of the trial, and hopefully see you soon.
Great, I hope that showed okay. Yeah, I had my haircut since then. I still can't show you my face, but I'm going to try and show you the last couple of slides and then we'll finish. So As you saw on there, we realised that, you know, post-COVID and still now, all this time later, that was a year and a bit ago, you know, people are still not really coming back to hospital for post-operative physical wound reviews. And we had to implement video follow-up. The key issue is that quite reasonably, when we come to write up this paper, the world is going to say, well, yeah, but you changed your study, you know, 1,700 patients in, you completely changed your primary outcome assessment, which is somewhat unavoidable, but we are still, you know, working out how to validate videos. And that's the theme of the last couple of talks, isn't it? And we've been trying to work out what to do. You know, we thought pre-COVID videos would be useful to assess as part of this very big trial. So wouldn't it be nice to get some 30-day patients to video call us the day before they come to hospital, then get them to see them in person, and, you know, compare the two in terms of the intervariability and the fidelity of doing it remotely. But we can't do that. We just, you know, the primary outcome at 30 days simply has to be done this way, on video or even on the phone. But video is what we're pushing to our sites. We've been trying to work out what to do, and we're also, you know, very keen to maintain that this study is an observer blinded trial. So the person looking at the wounds was not in theatre, and that adds to the complexity in terms of who is doing the assessments. Video phones on the ward we thought was an issue before. It's interesting, when visitors are not allowed in hospital now, in most hospitals still, certainly in mine still. So actually video calls on the ward are quite normal, and I've spoken to various relatives on video call whilst doing ward rounds over the past few months. But trying to work out what to do, and we thought we'd pose this as a design challenge, but given the time, I'm going to just show you what we are doing, or what we propose to start doing in the next few weeks. And that's another SWOT. We like a SWOT, a study within a trial. What we're doing is, for that pre-assessment wound review, so on that day 5 to day 7, roughly, wound review, we are going to video call the patient on the ward. Which we can actually help set up, you know, by one of our research nurses helping the patient get online and get around some of the technology issues. And we can then do a video call with someone who's blinded, and then the same day, maybe 5 minutes later, someone else. And we think that one of the benefits of this kind of study with lots of trainees and research nurses and various people involved is that someone else can come along and do a live wound assessment. And that'll allow us to do a same day comparison of what the person on the video thought with what the person in real life thought. And it's the best we can do. And the caveat or the issue is, of course, the wound looks different when it's fresh at day 7 to when it looks at day 30 when it's healed somewhat. But I think, you know, for the purposes of picking up a wound infection, I think it's the right SWOT to be doing. And we're just launching that now. And we'd love to know if anyone's got any bright ideas how to do it better or more effectively, to try and get some real world evidence in a few centres of some assessments. And I think the secondary benefit may be that these patients will then know how to do a video call for when we do their 30-day follow-up at home as well. So we heard a bit about James's great work in Talent Plus, and we're still looking for the results of that stuff. He presented the world's first look at the acceptability data. We're going to do this SWOT, and we're going to come back next year and tell you what we found and just how good the videos were compared to the real life assessment. I'll finish there.
Thank you very much. That was, I mean, this is the real challenge, isn't it? And I mean, it will be important in future for clinical practice, I think, but yeah, highlighting some of the problems that we're facing both clinically and in research. So we have only got 10 minutes now for questions. We haven't had too many posted, but there are still a large number of people in the audience. So I hope that you've all enjoyed the 4 presentations this afternoon, which all have the same theme, which is around outcome measures in both wound healing and surgical site infection. So there have been some questions posted over the course of the 4 presentations. So the first one was posted by Alison and is a question, I think, for Rhiannon, and which is, she's asked what is it about electronic data collection that you think has encouraged a large response rate?
Well, anecdotally, and we're going to explore it a bit more with some qualitative interviews, but my inclination is that it's just the convenience. People are so familiar now with doing these sorts of things, online surveys, quick feedback, that kind of thing. As we've seen, the access to kind of smartphones and stuff is just ever increasing. So I think that's very encouraging. But as I said in the talk, there's still there's more people that aren't responding, and there's this big issue about access, and we have to think about equality and diversity and things, and that's a big area that we should be focusing on.
Yeah, okay, yeah, that's a really important point. And there was a question as well, Rhiannon, about permission to use the wound healing questionnaire.
Yeah, so I responded online. It's freely available, and yeah, you can use it for non-commercial use with no fee. You just request a license through the Oxford University Innovation, which are the company now that are just managing the distribution of the questionnaire for us. There is a fee applied if it is for commercial use, but yeah, we want everyone to use it. It's been developed with a lot of people involved and patients involved, and the idea is that now get the ball rolling, and hopefully it's something that's been needed in the field for a while.
Yeah. A quick question for Amber. The Burns core outcomes set, is it being applied in any trials yet? Obviously there's a lag time between.
Yes. I finished it last autumn, and it actually is already being used in a randomized controlled trial in the Netherlands. They're about to start that. I think they're still going through the ethics process. It's also being used in a national registry for children with burns in New Zealand. So it's early days yet, but it is being used already. Thank you.
Well, that's good. That's really good. So international impact, which is unbelievable. Yeah,
thank you.
Great. Thank you. There was another question from Alison. I don't know what your surname is, Alison, around colour blindness. So if I mean, I hadn't really thought about that. So I suppose that applies in clinical practice as well. But is that something that we deal with in wound assessment? And is using photographs or video, does that make it worse? Anybody know about colour blindness? James, you've unmuted.
I don't know specifically about colour blindness. You mean of the assessor, I guess. So yeah, I mean that is a challenging area. I'm not sure, but I definitely know that from our experience across lots of different ethnicity groups within the video follow-up, then there is definitely difficulties in detecting redness, for example, in lots of different skin types. And what we found from my interviews is actually that one of the features that people look for is kind of shining and tenseness of the skin rather than redness itself. So I don't know whether that sort of feature is easy to see on video, for example. And so Rhiannon's point on equality, diversity, inclusivity, and making sure that we have a really broad representative group of patients in all this research we're doing in this area is really important for the agenda moving forwards. And I think somebody mentioned, I think in the chat about kind of AI, and I know we had a session a couple of years ago now with people applying AI to tens of thousands of wound images, and I suspect the future will not have any clinical assessors, and there'll be some deep learning algorithms that will be detecting SSIs for us, I suspect.
Yeah, so so Tom, do you want to add to that? And Catherine, I don't know if you wanted to.
No, it's a really good point about the different skin tones and making it harder. I mean, the Bluebelle questionnaire, which is brilliant, and one of the key things when involved in developing that got added to the existing ones, as Rhiannon will agree, is smell. And it was and we haven't got photos or video cameras that can do that, and that's that you know is an issue that you get in real life that you're never going to get with any of these, which does kind of worry me somewhat.
Yeah. Do you want to add to that, Catherine?
Yeah, I think just to say, I think the issues that Tom and James have mentioned and that Alison raised in her comment, I think really go to demonstrate how difficult it is to perhaps make that jump from face-to-face direct visualization into something that's more remote. And I definitely think there are things that we need to think about and explore more broadly in terms of how we actually facilitate that, so that we can do this with all sorts of patients, but also have that opportunity, particularly clinically, that anybody can do that, you know, taking into account all of the things that we've been talking about. So I definitely think it's something we need to think about going forward. I don't have an answer now, but yeah, it's a good thinking point.
Yeah, and I mean the smell thing, I'd forgotten about that, but there's sniffer dogs, isn't there, in nursing homes and things now, but yeah, when you're an elderly care nurse, you don't really need a sniffer dog. When you dealing with urine infections, that is the sign, isn't it? It's yeah. So okay, I think we've run out of questions. My alarm's telling me it's 5:20, and so the session has concluded. I think it's been fascinating. It's definitely work in progress, and thank you all for your great presentations. And it's the data is still emerging. So thank you all.